Hello, I'm Tim Brand, a urologist from Madigan Army Medical Center, and today I'll be presenting to you the highlights from the SLS robotics session from yesterday. We'll be covering approximately 8 hours of programming in the next 7 minutes. So the session started with Farid, who spoke to robotic surgery for giant hiatal hernias, and he said the robot has allowed us to do a chest operation through the abdomen and showed us some very nice videos of repairing giant hiatal hernias through the abdominal approach with the robot. Samay Jain then spoke to complex robotic assisted laparoscopic urinary reconstructions. He gave us some key tenets for successful completion of these procedures. He said to spatulate the ureters, create a tension-free anastomosis, stent and drain, and as with most reconstructive procedures, always have a plan B. And these same messages were conveyed by Raju Thomas later in the day with his robotic-assisted urinary reconstruction talk. Robert Poston gave to us the value of robotics in a new era, an era of bundled payments, and he transformed conventional conventional wisdom to current wisdom, and he said that robotic surgery is slightly more expensive during the implementation phase, but after we're converted to bundled payments, you do better with the robot due to a lack of complications than you would do with open. Mona spoke to complex robotic hysterectomy. Here in this video grab on the top right, you can see her fourth arm is holding over an enormous uterus, and she has isolated the triangle of freedom, as she calls it, as she dissects her way down to the uterine artery to control this situation. She advocates for a complex robotic hysterectomy to be done with the robot in cases where there's a large uterus, a high BMI, or complex pathology. Colin Brathwaite spoke to robotic bariatric cases and demonstrated the benefit is less leaks and showed an exceedingly low leak rate compared to laparoscopic cases. And you can appreciate why when you watch the video of his hand-sewn anastomosis and how well it's done. Jay Reedon spoke to credentialing for robotic surgery and demonstrated how variable the credentialing is from system to system. He charged us as surgeons to lead our organizations, such as the SLS, to standardize robotic credentialing process. Joe Ruerda spoke to robotic esophagectomy, and he said that the hand-sewn anastomosis has a very low leak rate. And here's a video grab of him completing the anastomosis. He also said the randomized controlled trial is complete. And spoiler alert, they are still doing the robotic esophagectomy. Robert Poston spoke to implementation of robotic coronary bypass surgery. Here's a graphical representation of expectations versus performance. And you can see that during the early adoption phase, there's a gap where expectations far exceed the performance. But he advocates to deliver this message to the administrators prior to implementation so that they can anticipate this gap and ride out the storm to reach the plateau of productivity where there is demonstrated value to robotic coronary bypass surgery. Raju Thomas spoke to robotic reconstructive urologic surgery. He simply said, if the wire goes up, it is a good day. Mona came back to speak to the state-of-the-art in robotic myomectomy. She confessed she has a red aversion. The way she avoids this is with a tourniquet, umbilical tape around the uterus, or vasopressin injected around the fibroid, or clamping using urologic partial nephrectomy bulldogs on the uterine artery in order to complete a bloodless excision of the fibroid. She also confessed she has a ureter paranoia, so she advocates to dissect out the ureter to ensure that it avoids injury. From the afternoon, Christina Kim presented on robotic ureteral reimplantation. She said that with the robot, an extravesical ureteral reimplantation is able to be completed bilaterally without the urinary retention that's been traditionally seen in open ureteral reimplantations for reflux in children. Jessica showed us that Firefly can be used to identify intraperitoneal studding with endometriosis, thereby avoiding the need for future surgeries and more completely treating this condition surgically for the patients and avoiding recurrences. Amir gave us a glimpse into the future for the robots, small, versatile, and flexible. He showed that future generations of the robot may be bed-mounted, also advocated for some supervised autonomy for these robots, similar to how a pilot would use autopilot for landing an aircraft. Jay came back to speak to remote proctoring for robotic surgery, telementoring, and he said that telementoring is essential for the expansion of surgical skills assessment and teaching. Lastly, from the fellowship session, Far Najat spoke to the need for surgical training fellowships. He said very eloquently that we need to do this to pass the truth to the next generation, teach them early what we learn late. And Cameron Najat spoke to why he teaches and simply said, if your plan is for 100 years, it's imperative to educate, which is why he supports fellowship training. And lastly, Ashley Bartolo spoke to work-life balance. She said the key to remaining productive and healthy in a busy fellowship or busy staff position is a combination of diet, sleep, and spin, which aligns well with the Army Performance Triad, which recommends sleep, activity, and nutrition in order to maintain this balance. Thank you.